We'll begin with the presentation by Dr. Joanne Ngeow, medical oncologist, National Cancer Center, Singapore, who will speak on cancer genomic medicine, lessons in implementation. Ma'am.
Hi everyone. I think everyone's still at tea break, but we'll get along. Thank you very much for the organizers for inviting me to this talk. I'm going to speak about cancer predisposition in the Asian context, and I'm going to give you actual insights from studies that we've done over the last 10, 15 years in Singapore, and some of the lessons in terms of what it might mean if you want to start a similar program in Bangladesh. But before I get there, all right, I just want to, again, thank everyone. It's my first time in Dhaka. It's been already a very amazing trip. I want to actually acknowledge Associate Professor Mustaq, who's sitting in front there right now. He did a wonderful workshop yesterday where he got together multi-sectorial, multidisciplinary group of academicians, clinicians, industry, students. You know, that's what's actually going to need to happen if Bangladesh or any country wants to embrace new technology into the healthcare system. Be it genomics, be it AI, whatever the new technology is, you're going to need a whole multi-sectorial effort. Someone's going to have to teach the folks who are going to have to work in the laboratories. Someone's going to have to upskill all the various clinicians. And then the policymakers themselves have to be upskilled because they need to understand how this is going to affect the bottom line when it comes to healthcare budget. So it's really, this hope and this desire to actually be doing this needs to be multi-sectorial, and I'm very glad we were on that journey starting yesterday, and today is probably the second day of that journey. So in terms of my talk outline, I'm going to give you a peek of data that we got from Singapore context. I'm going to sort of mention some of the real-world barriers to implementation in Asia and Singapore context, how the lack of population data will affect the kind of results that you'll be getting from genetics, what that would mean for clinical care, how it would make things not so straightforward for you guys, and how we, at least in Singapore context, have tried to overcome some of these barriers. I like to start any talk I give in Asia with this slide. This is created by my friend Jeremy Lim. Asia is not a country, Asia is a continent, and we're very diverse. Unfortunately, in this particular slide, the South Asian countries are not on it, but I don't have Bangladesh there, but you can see between Vietnam, Singapore, Taiwan, Hong Kong, Japan, Malaysia, Indonesia, we have very different epidemiology, and we have very different health systems. So for example, in Vietnam, the most common cause of male cancer there is still liver cancer due to hepatitis B. In which case, if you want to do a public health approach to cancer prevention, it's very clear genomics is not the first thing you think about. But if you look at Singapore, Hong Kong, Taiwan, Japan, and the rest of it, you know, where breast and colon cancer, it's already in the national screening programs. And these are two cancers where, as part of the national screening programs, genomics plays a part, because genomics can tell who's high risk, who is less high risk. And this is in that context that you want to consider how genomics has a play in public health. I saw from earlier sessions that breast cancer is incredibly high in the Bangladeshi population, and as such, when you are planning your breast cancer screening programs, I do believe it is time to think about how genomics play into that. Same for colorectal cancer. But it might be quite different if your epidemiology is lung cancer, then tobacco programs would be the key thing that you want to think about in terms of your healthcare dollar. So I'm trained as a medical oncologist, and I spent actually less than 6 months being a medical oncologist because I wasn't quite as interested in what we call the reactive care component of it, whereby you were treating patients once they were in the metastatic stages. After medical oncology training, I went off for further training into genetics and genomics, and the idea is how do we use genetics and genomics to shift our ability to pick up people before they got sick, before they developed the stage 3, stage 4 cancers, help us detect them much earlier. And if we can do that, it's better for the patient. It's also much better for the health system and for the overall healthcare budget as well. So I work mostly on trying to use genetics and genomics, not for targeted treatment, not for precision medicine in the sense of tailoring drugs, but in the sense of trying to understand each individual's risk profile and how we use it to do that. Singapore is considered a fairly developed country, but I can tell you that our screening rate for breast cancer is very low. It's only about 39%. And this is despite many campaigns and creating free screening for people and all that. And it's far cry compared to the US 72%. Part of that reason is because when we provide screening for average risk individuals, an individual may not feel compelled to go there because they don't feel it relates to them. So that's one part of the problem. There are also other issues as to why people are not taking up screening that is part of another talk that I can give. But whatever it is, doing the same thing over and over again isn't helping. We need to do some things differently. So over the last 15 years, I've built this program. It's a 15-year program. It's been going on since 2010. There are various components to it. One component is the clinical component, where we have clinics, where we have genetic counselors who are talking to patients, talking to families, getting them pre-test counseling, giving them genetic testing, post-test counseling, and we're managing the whole family. We have, as part of that program, we have biobanks and repository to collect the samples so that we actually understand what's the underlying genetic epidemiology, and also then a very big outreach education program, which you'll hear a little bit about. So I'm going to share with you some of the data from this part. But for today's talk, I'm going to say, if you are considering making this a program here, you need to actually convince not only your patients and the public, but mainly the policymakers that this is an important thing to do. And these are some of the things I got asked 15 years ago. The first question I got asked by my policymakers was, this does not happen in Singapore, there's no data on this, means it's not there. So what they want to know is, how common is this in Asia? How common is hereditary cancer syndromes in Asia? Do the patients want this? And then the last one is, can we afford this? I won't cover can we afford this, but I can cover the first two today. So, problem one, what is the local population data in Singapore? I was fortunate to be one of the PIs under a very big study in Singapore where we looked at the first instance, 10,000 Singaporeans. These are not people with cancer, these are general population people. And we looked at the 10,000 Singaporeans, we did whole genome sequencing, and we looked at how many of these individuals were born with a higher risk of developing cancer due to a genetic mutation. And based on that data, what we find is that about 4% of the Singapore population is actually walking around with a genetic mutation that's actionable. This is not just for cancer, this is for all medical conditions. So including things that puts you at risk of high cholesterolemia, hypercholesterolemia, putting you at increased risk of early heart failure, cardiomyopathy, but also including cancer. And within the cancer group, it's too small, you can't really see it, but the different color bars refer to the different ethnic groups, Chinese, Malay, and South Asians, or in the Singapore context, we lump them all as Indians, but we know it's not all Indians, it's all South Asians. So Chinese, Malay, and South Asians, what you see is that across the ethnic group, there is no one race that has a higher sort of burden of genetic mutations for increased risk of cancers as a whole group, looking at all the genes. But if you drill it down and look at it more closely, for those of you who are not familiar, HBOC is hereditary breast and ovarian cancer syndrome. You've heard multiple talks about BRCA1 and BRCA2 and how that may be useful for knowing who might need olaparib treatment. But these patients have a high risk of breast, ovarian, pancreatic, and prostate cancer. So in the Singapore context, for the first time now, we have data about how common this is in the Singapore population. We have 1 in 150 Singaporeans walking around actually have a mutation in BRCA1 or BRCA2 or PALB2. And it's more common in the Malay population compared to the Chinese and the Indians, okay? And this is the first time we have this data that allows me to then go to my policymakers and say, you need to do something differently because it's quite common. It's not as uncommon as you think. Now, Lynch syndrome, I'm in a breast cancer conference, but I just want to share with you about Lynch syndrome. Lynch syndrome is another set of genes that gives rise to colorectal and endometrial cancer. In the West, the prevalence is meant to be 1 in 250 to 1 in 300, but in the Singapore context, at least in this first 10,000 patients, we see it only in half of that, 1 in 500. But what's most interesting is that the 1 in 500 is driven primarily by those Chinese in Singapore. It's present in 1 in 400 Chinese. In the South Asian and in the Malay population, it's a lot less common. Why is such information important? I can give you an example. We have been running support groups for Lynch syndrome for many years, and I only saw Chinese patients in the Lynch support group. I never saw Indian patients, I never saw Malay patients. And I used to tell my team, you're not working hard enough. You're not producing enough material in the different languages, so you need to work harder. But when this data comes out, we realize it's actually twice as common in the Chinese population compared to the Malay and Indian. So it will change how you would manage patients. So this is another way of me presenting the data. 1 in 150 Singaporeans are at risk of hereditary breast and ovarian cancer syndrome. What this means, and as I tell my policymaker, is that their current guidelines where mammogram starts at 50 years old is wrong for 1 in 150 of the Singaporeans, because it's not taking into account the fact that they have a higher risk of this, right? Policymakers don't like to be wrong. So if you want to sort of get policy to change, you may want to tell them when they're wrong and use evidence to show them that they might be wrong. So why am I saying all this? Why should people in Bangladesh care about the data that I just showed you about in Singapore? I think it's important because before this, we didn't have this data. We just took the prevalence of things from other countries. I think it's very important that in every jurisdiction, and with 190 million people in Bangladesh, it's quite important to have some understanding of what actually that risk is for your population. So I'm going to switch gears now. That was data from the general population. Now I'm going to look at our cancer center data and what that looks like. This was done some time ago, but this is about 3,500 individuals who had next-generation germline sequencing done in our clinics, and it's across all the different cancer types. Just to highlight to you that, for example, the prints are too small, but basically for breast cancer, the bigger circles were BRCA1 and BRCA2, as expected. For Lynch syndrome, and all, it's basically the genes that you are concerned about in the West. They are present. They are the same genes that are what is driving disease in Asia. And we have an idea of what that spectrum looks like now in the Singapore context. But what is important is also when I compared the data from the cancer cohort with the population cohort, there was very little overlap. There was only about a 14% overlap between the actual variants that were seen. What this means is, unlike in some countries, we need to do next-generation panel sequencing because these are unique genetic changes in the gene across the gene. This is different, for example, than Israel. In Israel, for BRCA1 and BRCA2, 98% of the mutations in that population is only caused by 3 specific mutations. And you can then do a very cheap kind of testing of the whole population for those 3 mutations, and you will understand what it's going to be like for the rest of the population. But in the Singapore context and in most other countries, because we are very admixed, we have a lot of people moving in and out, you can't do what we call founder mutation testing. And so this is data for us that we can't do that. This is so a lot of us think about hereditary cancers or inherited cancers based on family history. Do you have a family history? Do you not? This is what we teach our medical students. But the truth of the matter is, again, the slides are very tiny and it's not coming out so clearly, but what it shows is that actually the family history is only useful in a few of the genes, not all the rest of them. And even within the genes, there's specific variants that are driving. So you cannot rely on family history, essentially. Family history alone is not reliable. A lot of these patients who were mutation positive actually did not have a family history. So family history is helpful, but it's not entirely reliable. This is another one that patients, that my clinicians or my policymakers ask us. Can we use age as a cutoff? So, we can't test everybody. Can we just use age? Maybe age under 50, Can we use age to see who needs to have testing, who doesn't need to have testing? What this data suggests is that for breast cancer, the red line is the age of 50. Some people are above, some people are below the age of 50 who test positive. You look at colorectal cancer, majority of them were above the age, etc. The only one that you can really use age in the Singapore context is pancreatic cancer, less than 50, maybe a way of differentiating who needs genetic testing, or pheochromocytoma. Definitely, the younger they are, the higher likely that this is due to a genetic mutation. However, for pheochromocytoma, which is adrenal gland tumors, all of them should be having genetic testing because that condition, many of it is due to genetic reasons. So basically, the last two slides is saying that family history and age are both not very reliable. Okay? So this then becomes a little bit challenging. All right. The other problem that you will have in the Asian context is this thing called VUS. All medical oncologists and all treating doctors must eventually understand and know what to do with what we call VUS. VUS stands for variants of unknown significance. Increasingly, when you send for genetic testing, 3 possible results can come back. Positive, meaning that we found what we think is the causing mutation. Negative, meaning we didn't find anything. Or you get a variant, and the variant is not yet clear whether this is going to give rise to the disease or not. So VUS is an important topic, and it is definitely a bigger problem for people in Asia than others. The reason for this is because we have a lot less population data. So whenever you do a genetic test, the first thing that happens is when we find a genetic change, it will say, how common is this change in your population? If the change is very common in a Caucasian population and everybody in that group has never had cancer, then it's very likely that that's benign, all right? But if the question is then, how common is this genetic change in the Bangladeshi population, and there is no data, then we cannot tell, is it going to lead to cancer or is it not going to lead to cancer? And as a result of that uncertainty, it gets labeled as variants of unknown significance. When something is labeled as a variant of unknown significance, when more data comes about, it can be reclassified. So I think the clinicians need to understand that genetic testing results is dynamic. It is an interpretation of it. And that interpretation is dependent on data. And when data changes, the interpretation does change. All right? So we have data from Singapore. 50% of anybody right now in Singapore who undergo a panel NGS testing will get a genetic result that comes back with a VUS inside there. And after following up these patients for 6 years, meaning that there's been 6 years of additional data coming through, only about 10% of those variants are reclassified, meaning majority of them still remain uncertain. Uncertain results should not be acted upon. They are not useful for the doctor, and they are also not useful for the patient. So 50% of patients may be getting something that may not be very useful for them, okay? And this is something that's important. I think one key takeaway message that I want to put here clinically is that if you are a surgical oncologist, and if one of your patients have a BRCA1 VUS result, you should not be offering that patient prophylactic surgery, removing the breast or removing the ovaries, unless there is a very good reason to do it. There's a very strong family history, because some of these patients, actually the variant is pathogenic, but because the data is not 100% confirmed yet, the lab still reports it as a VUS. You should be consulting with someone from genetics if you're going to do that, and taking out, breast and ovaries and the rest of it. So, but in general, a VUS result should essentially be treated as though it's negative and not positive. Okay, so the other question I have is, I was asked is, now for the more common genetic conditions in the Asian context, what is the lifetime risk curve for these patients? And so this is the largest study that was just published earlier this year between Malaysia and Singapore of about close to 600 families with BRCA1 and BRCA2. And what you can see in a lifetime risk curve, I know medical oncologists are very used to only Kaplan-Meier survival curves, but I'm introducing you guys to another risk curve. It's called a lifetime risk curve. In a lifetime risk curve, the x-axis is age, how old you are. The y-axis is if you've developed breast cancer or whatever the phenotype is. So in this thing, the dotted line at the bottom is the general population. The colorful lines on top there is basically the lifetime risk of people with BRCA1 and BRCA2. And what you can clearly show is that the breast cancer risk and ovarian cancer risk is many, many times more than the general population. Anybody can tell you that these two groups should not be managed the same way because the lifetime risk curves are so different, all right? Now, even more interestingly, because we had Malaysian data and Singapore data, when we looked only at the Chinese because the Malay and the South Asian population were too small. In the Chinese-Singaporean group, our lifetime risk of cancer was closer to the UK and the US patients with the BRCA1 and BRCA2 compared to Malaysia. So even though we might be more genetically similar to our Malaysian, like the Singapore Chinese and Malaysian Chinese, we were once the same, right? We were all once Malaysia. Even though we were the same BRCA1 or BRCA2 mutation, there are other things like lifestyle, reproductive history that has changed the actual risk of this. So there are other modifiers that can modify the genetic risk. So this is probably one of the first papers that actually shows this in a very clear way like this. And we're likely to see this, I think in Bangladesh, you have a different lifestyle. You have a different reproductive history, meaning that you may have more children here than Singapore, where I think it's quite famous that Singapore is, I think Elon Musk said Singapore is going extinct because our fertility rate is less than 1. All of these things are risk factors for breast cancer and has an impact on it. So having said that, that means that a germline BRCA1, BRCA2 mutation in Bangladesh may not be the same. We just showed that even between Singapore and Malaysia, it's not the same. And we're so close to each other. So all these risk estimates needs to take into account not just the genetics, but also the environmental lifestyle factors. Okay, this is from a clinical perspective. A lot of clinicians will say, so what? What's the point of knowing this risk? I showed you earlier that the general population who does not know their risk, the mammogram uptake is only 30%. In the patients that we look after, when they know their risk, the uptake of screening is between 70 to 80%, okay? And patients actually are smart. If you treat patients as smart people, they are smart back at you. When you tell them that this is their risk, this is what they need to look out for, they are worried. They will go for testing. They will go for screening. And so far, our patients we've been able to pick up early cancers in these patients quite regularly and quite frequently. This is actually the Singapore hospital data from SGH. We looked at 2 million patient records that come into SGH. And even in Singapore, only 75% of people who meet testing criteria and 85% of people who meet Lynch syndrome testing criteria still have not had their testing done, which means that there's so much we can do in this space alone. Problem number 6, this is more from policymakers. They'll say to you, nobody wants this information, right? Patients don't want to know this. These are the support groups that we have. It's not true. These families have had multiple members of their families die of breast and ovarian cancer with HBOC or with Lynch, die of endometrial and colorectal cancer. They don't want that history to keep repeating. And this is again and again coming through in our support groups. We actually formally did a study to sort of rebut our policymakers, but I won't go through the design of the study, but I'll just quickly share with you maybe this slide here. This is a formal way of testing whether the person who's having the test, are they informed about it or not. So to make an informed decision, you must first be knowledgeable about the condition. You must then want the test, and then you go ahead. Your action is consistent with your desires, or you are well informed, you don't want the test, and you don't go ahead for the test. So both of these are what we call informed choices. What we show in the Singapore data is that the patients have very good knowledge, they have a very good positive attitude, but actually the one thing is, not the statistically significant thing is, they are not going for the test, the non-testers. So this means that it is not the individual who is not wanting to go for the test, but that at the system level, there are some barriers. And this is things like cost of testing, access of testing, insurance, and the rest of it. Okay, so that's at least in the Singapore context. In the Bangladesh context, I was told that insurance is not such a big thing on people's minds, so you don't have that issue. So you might be actually, once you make the test affordable, people may actually be more amenable to the testing. Okay, I'm going to skip this one. This is just some work that we've done to show how we can actually make this cost-effective for patients. Cascade testing is getting the family members to come for testing. All right, we have shown that when we take a very specific approach to this, we can increase the family members coming for testing from about 15% to about 30%, which is what we expect. We don't expect every family member to want to know their genetic risk, but about a third of them is about the global average, and this is achievable with certain information targets. I'm going to move quickly ahead because I'm 5 minutes from the end of time, but I wanted to show this slide. This slide is my meeting with the Ministry of Health to try and get some of these things happening. And you can see that actually to get some things approved, it is multiple divisions cutting across primary care, health services, hospital services, and all of it. And this is one of the reasons why such policy changes are very hard to do. And in the Singapore context, what they've done is they've actually removed this and they've set up a separate office to just look specifically at precision medicine. Because if you are trying to do this based on the current existing Ministry of Health structure, it's one of those things that cut across so many things is not possible, all right? The last thing that I'm going to talk about is for us to utilize genetics effectively in the clinic, we must first improve education and capacity building for the population, right? So how can we improve genomic literacy? I put this slide up because she's my mentor. She passed away last year, and I said for 1 year I will give all my talks with reference to her. She trained me when I went to the US, and then from there I came back here to Singapore, and I was able to do what I've done. So I believe very strongly about training people one at a time very well, having them then come back and do that gospel spreading for your country, all right? And so this is kind of what we have done. This is a photo of Mustaq. Mustaq is spending time with our fellowship program in Singapore. I think he's enjoying himself. But on the slide at the below, which was Chinese New Year, you will see that he's there. We have a Hong Kong fellow. We also have a Singapore fellow in that same photo. And the three of them have decided to work together and write a few grants together. So these kind of fellowship programs are really important for international collaboration and for training. And we've trained people all across the globe now in the last 15 years. And this is the kind of things that happen. We do hands-on kind of training about how patients actually can curate variants, understand what the genetics mean and the rest of it. These are some examples of things we do. We have set up a network for us to better understand how we can collaborate and how we can break down some of these barriers for implementation in Asia. And this is something that if you're interested in this space, I know in Bangladesh and this part of the world, you don't only treat breast cancer. This is for GI cancers. So if you're interested in hereditary GI cancers, the next meeting is in Singapore in March next year. Please, you're all very welcome. The meeting is coming to Asia for the first time because they want to hear what are the challenges in Asia. So my key takeaways, and I'm right on time because I have my clock here, is that germline cancer predisposition, which is that you are born with a higher genetic risk of cancer, is actually more common than is appreciated in Asia. Having it as a pillar of your national program is actually useful because it can then break down a lot of the barriers in terms of implementation. There's a great need for local data. I think I gave you the reasons why. Using the genetic driven management is very important. So if you know someone's very high risk of breast cancer in BRCA1 and BRCA2, you need to start your mammogram much earlier. You need to go and actually have risk-reducing ovary surgery in those who are high risk. There are very specific differences between some racial groups that can exist. In the Singapore context, it's not so great, but we don't know what it is for your country as yet. There is a lot of overlap between, the clinical cohort and the general population is limited, so you actually need to understand what is happening in both data sets. I showed you data that a lot of the barriers to testing, it's not because people do not want to know, it's because there are financial barriers and the rest of it. And then we're working a lot in terms of how to do a lot of this, but I think the two key things, the lessons for the last 15 years that I wish I knew before I started, was that you need to work very closely between the public sector and the private sector, and this includes your testing companies. You need to work very closely with your healthcare policymakers and the clinicians on both public and private side. The patient and public voice is really important to bring into this by having the support groups and having our patients appear in newspapers a lot to talk about why this information is important for them, really help push things along. So I'm going to end there. Thank you very much.